Hi everyone, and welcome to the Only Way is Ethics, episode 5. And we have Clive Flashman with us. Clive, thank you ever so much for joining. It's great to see you again, and we're going to have lots to talk about on this episode. So just a quick introduction from myself. So Clive is Managing Director of Flashfuture's Consulting and Chief Digital Officer at Patient Safety Learning. So I'll pass over to you, Clive, to give us a bit more about yourself, your journey in digital health, and then we'll have a chat.
Thanks, Dean. And Essex is looking very sunny today, and of course I'm from Essex originally as well.
You are.
And yeah, and originally when I was very young, I had a lisp. So of course I used to say ethics rather than Essex. So when I saw the title for this, that stirred some interesting memories for me, I have to say.
Yeah, no, absolutely.
Okay, so yes, I've got my own strategy and digital consulting practice, Flashfuture. And yes, I am also Chief Digital Officer for Patient Safety Learning, and more about that later, lots more, hopefully. In addition to that, there's some other things that I do and I've done, which probably are useful because they might give a bit of background to where I am now, a bit of my journey, I guess, as to how I've got to where I am. So another thing I do is that I'm Director of Strategy at ORCHA, and I have been for about 7 odd years now, since there were maybe 7 or 8 of us, rather than the dozens and dozens that there are at ORCHA now. So it's grown a lot, and huge kudos to Liz Ashwell-Payne for doing that, who I'm very lucky to count as a good friend.
Me too.
And then I've got 2 companies that I've set up. One is TradeAide, which helps digital health SMEs internationalize primarily to the UAE. That's relatively quiet because unfortunately, just before we launched, our main competitor decided that they were going to give their product away for free. So very hard to compete with free when you're in the marketplace. Yeah. However, the company that I've launched more recently is doing much more active business, and that is a company called BidShaper, with a co-founder who is lovely, the ex-UK CEO of Dignio, a lady called Dr. Eva Trajanovic. And what we do basically is we help digital, actually, frankly, any health and care companies to do grant applications. So non-dilutive money for them. We don't look at loans, but we look at the grant stuff. And basically because we felt that some of the larger companies that were doing that were not really health and care specialists, were using quite vanilla stuff, and it wasn't doing any good for the people that really needed their help. And we thought there was a gap. So that's BidShaper. In addition to those, I do mentoring on a number of digital health accelerators. NHS England Clinical Entrepreneur Programme being a key one. I think I've been doing that for about 7 years now. And then the other main one I do at the moment is the Hill in Oxford. I also do the AWRC one at Sheffield Hallam. Until recently, I did the London South Bank one. In the past, I've done Manchester, Edinburgh, and others that, frankly, I've forgotten. And then I'm non-exec director at SEHTA, the Science and Engineering Health Tech Alliance. This is a really interesting organisation because it's like a sort of a membership body for health organisations, mainly digital health, but health tech, med tech, some biotech. And it's got about 1,500 organisations, and it's helping them to be better at start-up and scale-up. So what do they need to know? And it brings together legal advice, it brings patent information, it brings, investors together in a board. So like a bit of a dragon's den, it brings together stuff around medtech regulation. So clinical safety, So there's a
Absolutely.
whole bunch of
Yeah.
stuff that it does to help these companies at relatively low cost. And then the last one, or the second one that I am a trustee at, is the Picker Institute. And for many people, this is the most interesting organization that they've never heard of. So the Picker Institute, which I have to admit, I didn't really know very much about it before I joined as a trustee. The Picker Institute runs all of the big national surveys for the NHS. So the annual patient survey, the annual staff survey, the national CQC survey, it runs all of those. And it sits on this amazing trove of information that it doesn't necessarily own. It collects it for these other organizations. But the potential to leverage that information to generate some incredible insights is vast. And interestingly, the Picker Institute, which has been going a couple of decades now, was the organization that gave us the term patient-centered. So, so if you're talking about, services being patient-centered, it originally came from the Picker, and I would urge people to look at the Picker principles. These are the principles for safer healthcare oriented around patients. And actually, in many ways, they are common sense, but it's worth having a look at those because they ought to be at the heart of all of the health and care services that we deliver today. So those are the main roles. I also lecture occasionally in digital health at the University of Cumbria, and I have done it at King's College as well. And then previously, I was president of the Digital Health Council at the Royal Society of Medicine, looking at how we could educate clinicians about the wonderful potential of digital technologies to help them. And I really enjoyed my time there, and it's now being overseen by Julia Manning, who is a fantastic president. And in the interim, there was Loy Lobo and Tim Ringrose, both of whom are significant figures in digital health. So I think that's a really interesting council or section at a very interesting organization, because the education syllabus for doctors doesn't really cover the sorts of digital health technologies that you'd think would be bread and butter today. When you and I can use these sorts of apps and, home consumable devices like Cardia to measure our health status and wellness, doctors should be trained on this as a matter of course, but they're not. So I think it feels a really important gap in that. And we do bring out safety as well as a key aspect within that. And then I recently, last summer, finished 3 years at NHS South Central and West Commissioning Sport Unit. I was their Programme Director for Digital Health Innovation. And that was an interesting experience going back into the NHS, because I previously left the NHS in 2007, which I'll tell you about in a minute. So going back into it and looking at all of the frustrations and the inertia and the political escapades that were being done by a whole bunch of different organizations, that was quite interesting to look at that again. But I think it was useful to be back in the NHS to see it from the other side. I was for 5 years in an NHS Special Health Authority called the National Patient Safety Agency. That's really where my passion around patient safety began. So that was 2002 to 2007, and I was recruited when the organisation was effectively being set up by Helen Hughes, who's now Chief Exec at Patient Safety Learning. So she's made the same mistake twice. She's hired me twice. Basically to set up a knowledge and information management team whose core purpose was to design and then oversee the building of the National Reporting and Learning System. So that national system for the collection of patient safety incidents, I put my hand up and say, that was me, I led on that. And the new replacement, learning from patient safety events, has taken quite a number of the things that we did with the National Reporting and Learning System. I don't think it's necessarily advanced it as much as it could have done, but I'm really interested to see what they do with some of the big data tools that are now available there, because it's now getting over 2 million reports a year. You know, there's a lot of things that you can do with that data, frankly. And then through the National Patient Safety Agency, I chaired the WHO Committee on Patient Safety. So I was out to Geneva several times. I sat on the NHS Information Standards Board. So I was part of the group that helped to set some of the standards that still prevail today around informatics. And then I was on Muir Gray's National Knowledge Service, and I bumped into him the other day at the Royal Society of Medicine, and he is still a lovely guy who is full of the most amazing ideas. And then I was also global co-chair of an HL7 Special Interest Group. So I'm quite au fait with FHIR and data messaging and all of that sort of stuff. Okay, I think that's enough for now.
You're a bit of a glutton for punishment, aren't you, Clive? With everything that you've done. I don't know where you find time to do anything else. I mean, it's an absolutely fantastic background, Clive, in patient safety, in being able to support the digital health community, startups. Something that I think we're both quite passionate about is innovation. I think we've spoken about this before around it's difficult, isn't it, for startups, and especially when we come on to sort of talking about sort of patient safety and clinical safety in relation to that, and we're gonna talk about that a bit later on, about sort of like the nuances, the differences, and the synergies between the two. But I think startups coming into the UK market at the moment with things like DTAC, medical device regulation, and all the regulations that get chucked at them left, right, and centre. And I'm gonna put it out there. If you delve into that market and you're prepared to move forward, it can get very expensive for startups, unfortunately. And you're talking around sort of the support that you give around sort of grant funding and in those roles as well. And I think it's that sort of when we talk about patient safety learning, and we apply that to startups, I think it's very difficult for them. And I find in my experience as well, in that the awareness in relation to that, do they do a good job when they look at some of these regulations? Where is the support that doesn't have a price tag on it in relation to sort of like, what do I do? How do I do it? Where do I go? Where do I start in relation to that?
And how much regulation do you need and enforcement? I mean, if you listen to Dr. Cypher Bed from Abed Graham, he will say one of the big issues is that if you don't comply with a bunch of these standards, there's no or else. There's no penalty. There's no, there's no regulator who's going to sit on you and say you have to do that. But then, we look at what's happening with the CQC at the moment. How useful is that sort of enforcement? How far has it got us? So it's a definite balance between a carrot and a stick. What I would say is, with regard to the clinical and the patient safety and the innovation side, it's a spectrum, or a continuum. At one end, you've got people that are absolutely obsessed with safety. And at the other end, you've got people that are absolutely obsessed with innovation and bringing the latest bright, shiny thing into the market at scale. And actually, the fine line that I walk on that is trying to find exactly the right spot where you can bring a level of assurance around safety to the market, to patients, but you're not stifling innovation. You don't want to be a massive blocker for innovation. You want to let good stuff come to the market, but you want to make sure that that stuff that comes to market is as safe as it can possibly be.
Absolutely, absolutely. And on that note, saying about sort of bringing things to market and being safe, you're right. There's a fine line, but have we saturate the market with regulation? Is it overkill? I think we talk about it all the time, and there's so many out there, and I know from my experience, you speak to not just startups but to all healthcare manufacturers, and they're like, they say, Dean, I found this other ISO, and I found another one and another one, and that one's harmonized with that one, and all of a sudden you get this big sort of like cacophony, and they start panicking in relation to that. And I suppose my advice and in relation to that is that you need to start with, I think DTAC is a good starting point in relation to it. It is a good framework. However, I think its implementation has been somewhat varied.
Yes, I saw this on one of your other videos, and you said, it's applied inconsistently. And I think that is the issue, is consistency across a lot of this stuff.
Yeah.
How can you ensure that even if you set standards, you set policies, that they are applied consistently across the whole system? And that's really, really difficult to do unless you've got the training in place that shows how to do this. So yes, CSOs are being trained, okay? But are the people in trusts and ICBs and wherever else, are they being trained on how to actually complete the DTAC for a new digital health technology in a consistent fashion?
Now, I'm a big advocate for training, as you sort of may be aware, sort of like Clive, and about consistent training as well. I think we both know, if we would talk about DCB 0129 and 160, the NHS safety standards, for those people out there that don't know what they are, they have a revision date of 2018 on them at the moment. They aren't. I'm going to put my neck out and say at the moment that they're not fit for purpose, because, and the reason I say that, and just to explain myself, is that we are accelerating, digital health is accelerating at such a speed, and dare we mention artificial intelligence, and
I think we should.
Everything. Yeah, absolutely, and everything that comes with that, because it's sort of like, it's out there at the moment, and we need to be mindful, we need to be cognizant of that, and that is not reflected in the standards. Some would argue that we've got AMLAS now, for everyone. So we love an acronym, don't we? It's the assurance of machine learning for autonomous systems in relation to safety assurance and the approach to be taken, which was produced by the NHS Digital Clinical Safety Team in partnership with the University of York, who have done some fantastic work around clinical risk management. And I don't know if you have had any sort of dealings with the University of York through patient safety.
Only because my son went there.
Oh, okay. Right.
But he's a computer scientist, but he left a long time ago. We did, as an organisation, Patient Safety Learning, feed in quite a lot of comments to the digital clinical safety strategy that Kelsey Flott led, and we were pleased to see that quite a lot of what we said made it in there. On the thing you were talking about, the DCBs, the only thing I'd say about that is do a word search for patient or patient safety, right? It doesn't come up at all, okay? It doesn't talk about patients, doesn't talk about patient safety. And for me, that is a massive gap, okay? Because you can't have a clinical safety case for the NHS that doesn't mention patients or anything about patient safety. So from my point of view, yeah, as you said, they're not fit for purpose.
It's fun. It's interesting you saying that, and it's something obviously that I think a lot of us have observed, because when it's a big thing, and a lot of people out there that listen to this will know that I've trained at the start of any training session on a whiteboard, and it takes up a whole whiteboard. So I need another one to do my notes and my scribbling. I put the word patient and put a big circle around it at the very start, and I say to everyone, that is our focus for the next 2 days, to try and keep people in mind, because we become blinkered, don't we? And lots of people do it, and I don't think it's not intentional. It's just that people go down a certain path. They're looking at functionality, system, and I think this has been mentioned on many other episodes as well, and I keep sort of banging on about it, is that the digital health technologies are there as an enabler for us to deliver effective care management. That's what they are. It's not the other way around. They're not dictating what they shouldn't. I say they shouldn't dictate. I know they do in some circumstances. They shouldn't dictate what we do and how we do it.
It's about being the intelligent customer, and when I was working particularly with the NHS CSU, but also occasionally I work with NHS organisations, and you've got to be an intelligent customer, and you shouldn't be supplier led. And it's interesting because I work a lot with the other side, with the startups and the suppliers, etc. But what you don't want is to, as a customer, look at the functionality. Oh, that's amazing. Yeah, we definitely have to have that. And we have to have that. No, I'm a great proponent of design thinking. And in design thinking, you start with the problem. What is the problem that you're trying to solve? And that's where you have to start on both sides. When you're the buyer, the NHS organisation, what is the problem that you have that you're trying to address? And from that, effectively, you start to create your specification. Okay. If you're the supplier and you've got this great idea, that is wonderful. You've got a great idea, but start with the problem. Is it actually a problem that needs solving? Because far too often I see these problems that are very niche. They're not commercializable. They're not mass market. And, it's not a massive issue. However, if we're looking at patient safety, and I think it's worth reflecting on the scale of the harm, that is a massive issue. So in the NHS England National Patient Safety Strategy that came out in 2019, and that is again something that needs to be revised, they said that there were 11,000 people a year, patients, needlessly dying in the NHS every year. Okay, now that number has not really changed materially for at least a couple of decades. Certainly when I was working at the National Patient Safety Agency, it was a similar number. So you could say as the population's gone up, the number or percentage harmed has gone down. Yeah, great. Okay, that's not fantastic. The aspiration in that strategy was to reduce the number of deaths in 5 years by 1,000. Well, you know what? For me, that's just not good enough. That's less than 10%. Now, having said that, we're nowhere near it. Because if you listen to Adrian Boyle from the Royal College of Emergency Medicine, his view is that in addition to that number, because of all of the backlog and the problems with people waiting ridiculous amounts of time in A&E and outside in an ambulance, or not going to a hospital at all because they can't face going to A&E, can't get a GP appointment, all of this, all the issues. Because of that, the College of Emergency Medicine says that they reckon there's another 23,000 avoidable deaths a year now. So if you look at that, 11,000 and 23,000, That's nearly 3 full plane loads of people crashing every week. Everybody dying on board. Now, if that was happening, if you had airlines where their planes were crashing every single week, 3 planes a week, there would be a huge outcry. Something would be done. The Civil Aviation Authority would be called in urgently. They would have to do loads of investigations. There would be new laws issued. There would be safety standards that would have to be applied. You can imagine, okay? You can imagine.
Yeah, totally. So why has
But
it become the norm then in relation to sort of, you know, patient safety and the NHS? It's, you know, with EPRs have come under attention, haven't they, in the past 2 years, in relation to, I mean, you know, just reading from your notes, Clive, in, you know, Royal Surrey, Durham and Darlington, and there's been others as well, Nottingham, and all around the, you know, the records, the patient records, however many thousand that it was, that either gone missing or
I think it was something like 500,000 patient letters haven't been sent.
Yeah, hadn't been sort of sent out, and you can, like, because, you know, myself and yourself hear those sort of stories, and we've got our head in our hands, haven't we? We're like, because we know, we understand, but how do we? And I think for me, it comes back to, does it come back to that awareness raising? Does it come back to, you know, asking the questions, using that same the comparison around the flights? And you're absolutely on the money. Can you imagine if we saw in the news 3 or 4 flights falling out of the sky every week? There would be uproar, and also no one would fly, Clive. You're hot, and if you put that to sort of like, you know, we don't have a choice. Patients, and we are patients, you know, we don't have a choice. You know,
Well,
if you are ill,
unfortunately, people are making the choice, because I'm reading articles. So, for example, Alison Pearson, the journalist, recounted the horrendous time that she had in A&E recently, and somebody else in the same article said, "Look, you know, I'd had a really bad experience, and then the next time when I got a piece of glass stuck in my hand, I couldn't face going back, so I pulled it out myself, bandaged it. I now have no use of my middle finger at all." Okay, but that's what's happening. People are not getting appointments. They are not able to face going to A&E. They're not getting appointments with their GPs, and it's causing harm, avoidable harm. And I know that there are issues with the whole system. It is in meltdown. I mean, there is no other way to describe it. The system is in meltdown. Okay, and I've been in healthcare for 30 years. I started off in a health authority in 1996. And so I've seen it all. You know, I've seen fund holding by GPs. I've seen everything. I don't think I have ever seen it this bad. I really don't think I have. Even before the Labour government got in 97, when it was pretty awful, I don't think it was this bad.
can we point the majority of that onto COVID and the pandemic, or do you feel that it was going in that direction
anyway? It was absolutely going in that direction. And, you know, we've had austerity since 2010, maybe a little before, actually, because Darling sort of brought it in a bit as well. But I mean, you know, Jeremy Hunt in his book talks about the mistakes that he made as health secretary. He didn't do any workforce planning. That's why we're in the dire state that we are now, having to import staff, competing against everybody else to import staff, because he didn't do workforce planning when he was health secretary. And he recognises that he didn't spend the money that should have been spent. The COVID inquiry will say that we didn't spend the money we needed on pandemic planning, you know. So it was going in that direction anyway. And COVID just accelerated it ridiculously. But there was no question that we were already going down that path. And it's not going to be something that is fixable within a single term of the government. I can't see any tangible change happening, frankly, until at least 8 to 10 years from now. which is an awful thing to say. And I'm interested to see what Darzi comes up with. And I have a feeling it may be a rewrite in some ways of his interim 2018 report, which in some ways was a rewrite of his 2008 report. But I think that we will see some motherhood and apple pie stuff, but we won't see any significant change until money starts flowing at the tail end of a second term of this government, if they get one.
Pretty scary, isn't it, Clive? When you look at it like that, and we're seeing. I mean, we've touched on sort of the focus EPRs being put in the spotlight, and I know I did want to touch on this, and we will sort of like have a talk about this. The BBC article that came out, the Freedom of Information application that was made, and the investigation by that team in relation to NHS IT systems and the scale of the problems in relation to that. And I know you were commented on that, probably out of context, surprise, as we normally get within sort of articles when they interview. And I know, us personally speaking, that you were sort of like, I was interviewed for an hour, and they came up, and they put they put that on there. It's a ticking time bomb. It's sort of like in relation to that. And I know a lot of those sort of the figures, etc. I've spoken to a lot of people about this article, and sort of whether it's sort of everyone should be starting panicking, etc. Yes, obviously, I think it is an area of concern. But that's not to say that area of concern wasn't there anyway. And I think all we've done is just sort of put the cat amongst the pigeons in relation to that. And, I get a lot of people coming back to me now and saying, oh, we're in such a dire state and we shouldn't be using all of these systems and they're not safe, etc. And it's like, whoa, hang on.
Yeah.
It's like you need to take a step back and calm down a bit.
I think a balanced view,
Yeah.
Are we saying that organisations should not implement electronic patient records? No. Should they stick with pen and paper or something? Absolutely not. Okay. Electronic patient records have a huge potential to improve the safety for patients in hospitals. Okay, undoubtedly. However, they can be implemented more safely than they are now. And so that's what we're saying. And the report came out today from Patient Safety Learning. We've literally today, we've issued, this is being recorded on 31st July, we've issued a white paper that summarises a round table that we had with CCIOs, CIOs, frontline clinicians, clinical safety officers, patient safety leads, non-execs, talking about how can we implement electronic patient records more safely. We're not saying they shouldn't be bought or configured or implemented. That's not what we're saying. We're just saying we're going to do it. How can we do it even more safely? Because patients are dying. If you look at Surrey, if you look at Durham and Darlington, patients are dying, okay? And the issue is that we need to bring people in who have a better fundamental understanding of the safety that is needed. So, for example, clinical safety officers. Clinical safety officers are often involved, once the system's been bought and it's been configured and it's starting to be rolled out. How can we do this in a safe way? Well, it's too late. It's too late then. Bring a clinical safety officer in when the system's being procured in the first place. When you're setting your specification, when you're talking about the safety standards that you want in your organization, that's when you need a clinical safety officer. That's when you need to have your patient safety lead. You should have a human factors lead as well. And most NHS organizations don't have them. I know that Surrey did have one, and they reported to the finance director, of all people, and got so disenchanted that they recently left. So those are the people that you need, because, you know, human factors. If you were building a head-up display for the new Tempest fighter jet, you're going to have human factors people who look at how the pilot interacts with those systems and make sure that they are designed in the best way possible. Okay, because they don't have a lot of time. Clinicians don't have a lot of time. You know, a lot of these systems, they use what you might call at a glance. They glance at the system, they need to know information very quickly, they move on. If you don't have that intuitive usability built in, that's not going to work. So, for example, in Durham and Darlington, the poor woman who actually had been a former employee of the trust, I think she was a dietitian, the woman who died waiting in A&E, she died because her level of acuity wasn't highlighted on the system. And it wasn't highlighted on the system because the previous system had used RAG ratings, red, amber, green, where red is high acuity. And the new system, and I'm not going to go into any system names here, but the new system didn't do RAG rating. And so you had to click through for an icon to see some text about it. And staff weren't necessarily going to do that. They had a mobile device in their pocket to look at, but they weren't doing that either. They just wanted to see it on the smart board or on the system, on the computer screen. You know, was it red? That's what they were used to seeing. Yeah. And the system vendor said, no, we can't do that. Sorry. And so the woman died because they hadn't recognised the level of need she had. There was a prevention of future deaths report that was issued not just to the trust, but also to the system vendor. And amazingly, that system vendor then changed their A&E module so that it is now RAG rated, which is great. They've done it after the fact. What I would say is, how many other NHS trusts that have the A&E module know that they can have a RAG rating and actually have implemented it?
And that's really interesting you saying that, Clive, because I was talking the other day about user groups and the lack of user groups in relation to, you know, looking at human factors, looking at UI, UX, looking at all of these areas in relation to, isn't it, workflow. How many times do we see or don't see within deployment, whether it's an EPR, whether it's a specialist system into a departmental system, how many times do we see people floor walking, actually going out and saying, right, let's walk through this process? It hardly ever happens. And I know people will say, well, we don't have the resource, we don't have the time. But if you do that risk benefit analysis in relation to some of those activities, it's sort of like, you know, you're putting yourself at risk if you do not do these exercises and you don't have these activities. And also, I think if you go as a voice to a vendor, and you know you are a collective of trusts, you can go to them and you can say, you know, and put your point forward to say these functions that we've spoken about.
Even more than that, you know, I was recently speaking at the Digital Health Summer School, and I talked about this. And I'd been to a session when I arrived because I was a bit early. And in that, there was someone speaking from the NHS England frontline digitisation team. Now, I'd not really heard about this, and they've partnered with PwC. PwC won the contract to do this with them. And basically, what they're about is ensuring that digital technology is implemented safely on the front line, particularly EPRs, but not exclusively, okay? Nobody in that room, as far as I could tell, had heard of this team. And when I was doing my session after that, I mentioned them, and there were a load of blank looks around the room. Now, that's what should be happening. These trusts ought to be working with the NHS England frontline digitisation team and PwC to bring together the learning and the issues and all of that. And as a group, fronted with NHS England, going to the relevant vendors and saying, that's not on. This needs to change. Or when you do the next patch of your system, you need to fix this or do that or improve your training on that, okay? Because NHS England has the ability to bring these people together to share the learning. And what better way to do that than feed it back to the vendors? Because often the vendors don't get it. How the vendors expected to improve their systems if they only hear it from one person at one trust, So I think we've got an opportunity now, as you said, through this type of user group, but potentially facilitated by the frontline digitisation team in NHS England, to actually en masse go to these EPR vendors and talk about what needs to change.
And you're absolutely on the money, because I think one of the big issues I think at the moment with digital health technologies and their deployment and their implementation, the relationship needs to be a lot better between vendors and health organisations. It's waning at the moment. That's my experience. And, there's not, it's almost like this, I worked for one for 11 years and, I know exactly what it's like, in certain circumstances. And, lots of people may disagree with me, but there's still that mentality sometimes of, oh, we've got the contract, we'll put it in, and sort of, they back off. It's that sort of like, in certain respects, I'm not saying all the time, or there's just a lack of appreciation in relation to, we need to be in there and we need to be making sure that everything's happening, especially when you get the attitudes of that I've seen recently as well, coming back to the clinical risk management side of things, is that when you're challenging a vendor around their 129 compliance, but at that point in time where you've been brought in, and this comes back to your point, Clive, around at what stage are you bringing in the clinical safety officer? When you're brought in at a stage, that project's been running for a year, the vendor's got pally with some senior clinicians within the trust, all of a sudden, you're getting fault from both sides.
Yeah.
So you're getting senior clinicians saying to you, why is this not going in? All of a sudden you've been brought in, you're a blocker. And when you're trying to explain, it's like, we're not blockers. We're here to protect the patient. We are here also to protect the organisation, to make sure.
The problem is, at that point, they start to say things that don't align with the full business case that the trust developed in the first place, because they weren't part of that. And that's why you've got to have this alignment, and you've got to have that involvement from day one, because
Absolutely.
that messaging has got to be consistent all the way through procurement,
Totally.
through the design and configuration to the implementation. It's got to be the same voice. And if you don't involve them, it's not going to be.
No, absolutely. And then you run into the difficulty. And I feel for a lot of clinical safety officers out there. And because I think as well, there needs to be support from the wider team. It's not just one person's job. A clinical safety officer, interestingly, talking about, is it a role or is it a function? How do we see it move? How do we see it moving forward? Within, we had the in-person CSO coffee and chat day with Kay Reynolds, Kay, Clive, and that was great. 50, I think it's the first time we've had 50 CSOs in the same room. I think nationally that is the biggest collection of CSOs in relation to that. And we had lots of breakout sessions, and one of them being around, the involvement of CSOs and how do we see that sort of panning out? What does that look like? Because I'm a big advocate in pushing forward the role that it needs to be a recognised profession.
Yeah.
And the way we can do that, speaking to Wendy Deering and a few other people around trying to get it onto core syllabus. And she said, the only way you're going to do that, Dean, is to get into the universities. It's not go into the NMC and the GMC and all of those bodies. You need to get in at the...
but also the CSO role is given to people who have a day job already.
Yes.
Okay.
Absolutely.
And this was very evident to me. I've got a friend of mine who is a clinician on an EPR program that was just going through the procurement stage. It's now decided who it's going to buy. And they were asked, and they're literally just done their CSO training. Okay, they're a very technically competent clinician, a consultant, but they were asked to do the CSO training. They did the CSO training, never been involved with a CSO hat on in anything. And then having gone through the procurement, basically that person was being asked to be the lead CSO for the EPR program for what I would call a fairly large acute trust, right?
Wow.
Because they weren't going to have to pay any more money for another person. That person could fit it into the clinical consulting and also the EPR clinical lead role that they were doing anyway. So they were basically doing 3 jobs, paid for one, and bonus for the trust. Now, it's about money, okay? And someone said to me on a meeting a while ago, well, would you rather that if we can't afford it, we didn't actually do an EPR? It's a good question, you know. And my answer is, do it the safest way that you can do it with the money that you've got. So that might mean that, first of all, you have to recognize it's not just about software licenses, it's about having the right people, like having your CSO involved, your patient safety lead, human factors, clinical leads, floor walkers, trainers, all of those sorts of people, okay? So the money that you get from the centre may not be enough. I mean, Frimley, which is a pretty good trust, recognised that it wasn't able to afford the level of training it needed, had to dip its hand in its own pocket and pay an extra £3.5 million for training its staff, okay? Now, you're not going to get all of the money that you need from the centre. You have to recognise that as a trust. Yeah. So what you do is you work out how far you can roll it out safely with all of that safety wraparound that you need. And if that is only 2, 3, 5 specialty areas, that's where you start, okay? You start with those, you do it properly, you do it safely. That rollout in the hospital where you've done it. And then when you've got the money, you roll it out to another specialty and another specialty. But you don't go everywhere at the same time with a very thin level of safety implementation, running the risk that you're going to harm people. You don't do that. So that's my advice. And with regard to the DCBs and other stuff, the point that was made on our round table, which is really worth repeating, is you do the DCB before you launch the system. When you put the system in 12, 18 months later, it actually doesn't look or operate in the same way that you expected it to before launch. How many organizations and indeed vendors are doing the DCBs 12, 18 months post-launch? They're not, okay? And I know they're meant to, but they're not. And I'm not just talking about EPRs here. I'm talking about, I don't know, surgical prehab. I'm talking about, stroke support services, diabetes monitoring. I'm talking about anything that a hospital can pay for and prescribe effectively digitally to its patients. If those digital technologies are being used, yes, do the DCB at the beginning, fine. But as a matter of renewing the contract, that DCB has to be redone. It should be in the procurement, okay? If it isn't, then that contract should be broken with reference to that clause, because you've got to repeat it at least at 12 months.
Couldn't agree more. And from my experience with EPR deployments, I think one thing that's missed or is not paid enough attention is post deployment monitoring, like you've just alluded to. And yes, I agree with you, Clive, around that sort of 12-month, 8 to 18-month revisit. It's absolutely essential because, like you say, things change. All of a sudden, we get that dirty word workaround. that sort of comes in, and it's like, oh, it's not a workaround, it's a new feature. All
Could
these
be a
different
shortcut.
sort of like,
Could be a
it's
shortcut
a,
as well.
a shortcut, a workaround, whatever you want to call it. In relation to that, we have all of these. But I think also what's essential as well with EPI deployments is that when you decide to go BAU, so you know, there needs to be a formal clinical risk management review, and I see those missed, Clive, a lot. People tend to, they say, we've ticked the box for go live, we've done our bit, we've got a hazard log, we've got a safety case report, etc. We're done.
Yeah.
Yes, we know it needs to be revisited, but that can wait, and all of a sudden it's not going to get done. Nobody's really sort of that resource, like you say, it's not my first job. That CSO now isn't a CSO, or they are, but they're moved on to sort of something else, and all of a sudden it's like that tornado, isn't it? It's sort of really going at 100 miles an hour, and then all of a sudden it dissipates and then sort of fades out and becomes clouds again. And that's sort of like the situation we're in. So I think I'd like to sort of get that message out there. It's really key that you do that, whether it's at 3 months, after a project, you have to revisit, and you have to do that with the vendor as well, because you'll start finding and you'll flesh out a lot of
let's get
issues.
the message to procurement people, who occasionally are the bane of the clinical people's lives. Actually, one of the things that should be put into contracts is the need to do this. And if it isn't done on both sides, potentially that contract can be broken. Okay, so that is a break clause. If this safety review isn't done by the NHS organisation and also by the vendor at a set period of time, that contract could be broken, okay, legally.
Yeah.
And that's a procurement thing. I think, there could be a little bit of a momentum around getting that put into contracts. But I wanted to pick up on something you were saying very early on about the difference between clinical and patient safety. So they're two sides of the same coin in many ways. And actually, what we see is that clinical safety and patient safety people don't often work together, which is awful, frankly. And that needs to happen a lot more. But if I was going to talk about them, what I'd say is clinical safety is all about trying to minimize or eliminate unacceptable clinical risk to patients. Okay? And it's about the management of risk related to clinical safety, and you can bring in information governance and finance and procurement and all of that, okay? But it's from the clinician's perspective, and often it's done for the clinician in terms of the way they work, so they can fulfill their duty of care, okay? They've got regulators, so they have to do that. It's also for the organisation. How can the organisation, from its reputational risk and everything else, manage this so it's done safely from a clinical safety point of view, okay? Patient safety is quite a different perspective. So patient safety is, and there is a definition for this, the absence of preventable harm to a patient and the reduction of risk of unnecessary harm associated with healthcare down to an acceptable minimum. Doesn't matter whether that's normal service delivery, whether that is technology, but it's all about making error less likely and reducing the impact of harm when it does occur. But that is the harm that reaches the patient. Now, that harm doesn't have to be physical harm, could be mental or psychological harm, could also be harm in other ways. For example, their data has been breached and circulated to people who shouldn't have it. Their consent hasn't properly been taken. So there's a whole bunch of things that relate to patient safety that are not necessarily the same as clinical safety. And I think it's worth just knowing that those, while they are related and in some ways similar, they are also quite different.
And it's interesting, Clive, when you talking about that, and you're giving those sort of like those great definitions, and that sort of comparison, but also the sort of highlighting the differences. But when you talk, interestingly, hearing you talk about the patient safety and lots of aspects of that, isn't it interesting that making the observation that there are digital solutions that support those areas of patient safety and can help in that process, and
Yeah.
and within those aspects, whether it, like you say, the consent in relation to that as well. So
Yes.
there is still that synergy, isn't there? Even though there's intrinsically those differences,
Yeah.
as
And
as well.
those tools for patients to help them are great. But on the other hand, sometimes those tools themselves can cause problems. So, for example, you know, patients might use a cardiac tracking app, and they might monitor what food they're eating, because they've got hypertension and they need to lower their salt. Okay. However, they might also have diabetes, in which case they're using a diabetes app, and the diabetes app says, well, you need to lower your carbs. And it gives them recipes, but those recipes are potentially high in salt. What you then get is, in the same way that you can have adverse interactions between medicines, you can have adverse interactions between digital health technologies. And very few people recognize that because digital health technologies are often fragmented and they deal with a specific issue for the patient, sometimes those tools will be in conflict with each other. And there's nobody who sort of takes a sort of 100,000-foot view and says to the patient, well, actually, if you're using that and you're using that and you're using that, just be aware that, for example, in terms of dietary planning or menu planning, you're going to need to have low sodium and low carbs. So look at both of these recipe sets, fine, but make sure that you've got that in the front of your mind.
And it's almost as if, and I hope I'm going to get this right. It's, and using the right sort of term, it's almost iatrogenic for causative factors for digital health systems. So all of those working together potentially are causing, or could potentially cause, the issues in relation to patient health, and therein lies a risk in relation to
Yes.
that, as opposed to sort of like that hospital admission and the hospital acquired, and the sort of the intent to help and to sort of and to treat. In doing so, we're potentially causing harm. It's an
Someone once
interesting
asked
concept.
me, someone once asked me if I could use one word to sum up the biggest problem in healthcare, what would that one word be?
Yeah.
And my one word, and I'm very interested to hear, you could open this up to people, what's the one word you'd use, or hashtag one word. So my one word is fragmentation. So it's fragmentation of treatment, it's fragmentation of the technologies, it's fragmentation of patient records, it's fragmentation of patient information. Fragmentation leads to inadequate, well, is a cause and a symptom, actually, both ways, of inadequate interoperability. So one of the main reasons that these EPRs, for example, don't fulfill their potential is that they're not open. They don't use open standards, and therefore they can't interchange data properly with other systems, even within the same hospital. So, for example, if you look at the recent case at Mid and South Essex, Laura Jane Seaman, okay, one of the reasons why she died, and the coroner's inquest was literally this week, one of the reasons that she died was because the different systems in the same hospital couldn't pass information between them. And, we've been talking for years about primary care and secondary care not sharing information. It's the same hospital.
It's the same hospital. You're right, and you're interesting. You're saying about your one word. Mine would be miscommunication, Clive, in relation to your fragmentation. Is because we see so much, don't we, of if we had effective communication within the NHS and like you say, within the same organisation. It's not that I'm not talking about communication between trusts or between organisations. I'm talking about core, that sort of, core patient centric, as we said, there it is, that patient centred communication that needs to happen, one department talking to another, not necessarily just by that digital communication, but just generally people sort of like communicating. If we improve that by a small percentage, I think we'd see great improvements holistically in relation to what we're doing. And I'd like to sort of lead that into. Now we've got a question here around fostering a safety culture within health organisations. We've spoken a lot around sort of, around systems, around initiatives, around what we do, advice we can give around the different organisations and institutes that are out there supporting the legislation, the standards, all of this stuff. How do we bring all of that together within a health organisation?
First of all, where are we now, right?
Yeah.
And while this is not the same for every single organisation, so there are pockets of good stuff going on, I think by and large, the way I would describe the culture in the NHS at the moment is toxic. And I really mean that. It is toxic. We've got duty of candor, we've got freedom to speak up guardians, we've got these various things we put in. They're not working. They're not working. Okay. So as an example, patient safety learning is probably the biggest knowledge and sharing site in the world for patient safety. It has nearly 12,000 knowledge articles, 20,000 pages in total, all about patient safety. And anybody who's a member, which is free, and by the way, it's pslhub.org if anybody wants. Anybody, cheeky little advertisement there.
Oh, but absolutely.
Anybody who wants to go on there, it's free to join. We're a charity. And you can post your own content on there. It is moderated, but you can post your own. Now, the majority of clinicians who post on there, and I know who they are because I'm a system admin, so I can see. Nobody else can see. But the majority of clinicians who post on there post anonymously. And we had to bring that in a few years ago because people were telling us that they were too scared to post their content on the site identifiably. For me, that is very telling. If you are not willing to actually give your name or your organisation or anything, that demonstrates the culture more than anything else. So what does this relate to? And I did a post on this recently on LinkedIn. For me, it was summarised very well by a post by Thea Stein from the Nuffield Trust. And she said for her, the missing link in all of this in the NHS is psychological safety. So if people feel safer, there'll be a better culture, there'll be more morale, better morale, people will feel happier coming to work, the workforce will stay, they won't leave, better retention, all of that. It all starts with psychological safety. Where does psychological safety start with? It starts at the top, okay? So I think that actually this is an area that we don't devote anywhere near enough time to. I know we've got massive conflicting pressures on our time. And in terms of your communication, your one-word communication, the reason that people will give for not doing that is well, we don't have time to tell everybody else what's going on. We've just got to get on with their own work. But actually, for example, the freedom to speak up guardian, I know from what people have told me that often the people they want to talk about in terms of speaking up are the people that that freedom to speak up guardian reports to. So you know, they're not going to start talking negatively about those people to the freedom to speak up guardian when they know that that is never going to generally be reported back. And if it is reported back, that might be a career limiting move. So, you know, there are some fundamental issues here around psychological safety. And actually, that has to start from the top. You know, organizations, yes, you know, they tick box around the Nolan principles, fit and proper person stuff. But actually, are we doing that really? Not just at the board level, but in our exec teams at NHS organisations. I'm not so sure that we are.
And I have to agree with you as well, Clive. And I think it has to start at the top. And we're finding that not just with, and it's really interesting actually, looking at your sort of, you know, leading into this episode and looking at your notes and the freedom to speak up. You know, did some sort of like, you know, looking into that. And it's really interesting because I'm trying to sort of, you know, lobby and do some work around governance in relation to clinical risk management. And it's very evident that that has to start at the top. When we're getting attitudes like from C-suite clinicians within digital health that are having conversations with their peers saying that clinical risk management is nothing to do with them, and that if anyone comes to me about clinical safety, I just pass it on to someone else because it's not my problem. That absolutely winds me up to the point of distraction. And I think it's absolutely disgraceful, and I'm not afraid to say that on this on the podcast, because that has to change. We can't have those people put into a position of responsibility, and I'll talk about it more in another episode as well. And what message is that sending to everybody? What message is
Not
that
the
giving
right
to
one.
their teams? Not the right message, absolutely. But it also begs the question: is how are they being put into those positions with those attitudes? And is that a lack of understanding? And if it's a lack of understanding, that's pretty scathing, because you know your role is, you know, whether it's chief clinical informatics officer. It's the clues in the title, you know, that you have a level of responsibility. You are there to champion those services, digital health, in relation to your organisation. As a clinician,
Yeah.
you have a responsibility.
But
And
it's also the other side, Dean. So I would go further, because you're talking about the NHS or buying organisation. I would talk about the vendors too. So, for example, we know recently this year that a chief exec of a fairly prominent electronic patient record supplier in the GP sector, well, actually multiple sectors now, came out and said some fairly awful things, but wasn't vetoed in the way that possibly they should have been, because potentially, allegedly, they were a funder of a major political party. Now, there's some stuff that's been done around something called the Equity Charter by Hassan Chowdhury, Aisha Rahim, Victoria Betton. That's a really interesting approach, because that then, if you link that to the fit and proper person test, Nolan principles, where that's from as well, if you bring that together, why shouldn't we apply those to the exec team of the key vendors for systems in the NHS? So, I mean, it's not everybody. I'm not suggesting that we do this for the tiny little vendors, you know, where they've got maybe a couple of thousand patients. But where you're supplying systems that affect, let's say, more than 250,000 patients, I'm being arbitrary here. I mean, picking a number out of the air. But let's say 250,000 patients, right? That's your scaling there. If your systems affect more than that number of patients, your exec team should have to go through the same sorts of processes that exec teams in public sector bodies should go through. Not all of them do, or well enough, as you've said. But also this equity charter, they should have to sign up to a finished version of that equity charter that talks about how they operate their business, equality for people, equity, even more important, for people, and the way that they recruit and train their workforce. So that's the sort of thing that I would like to see in terms of the significant vendors that the NHS engages with.
And I think that's across the board, isn't it, as well, Clive? I mean, I think we need to see more accountability by vendors in relation. And I know Dr. Saif Abed has also said around, you know, like we discussed earlier in the episode, you know, where is the accountability? Where are we in relation to, okay, you know, they're not 129 compliant. Some health organisations are taking the attitude that that's fine, we like the system, we're going to get it in, we'll put it in anyway, in relation to that. So that we don't have, where do we draw the line? And where is NHS England in this in relation to mandating? And everyone, you know, said, oh, but the standards are mandated. Mandated in what respect? There's no...
NHS England will tell us in the way that they told me when we had a bit of a moan at Patient Safety Learning about the quality of their patient safety alert around the maternity system from Euroking just before Christmas last year, that they don't have the direct contract with the vendor and therefore they have no direct influence over the vendor. Now, you know as well as I do that soft power doesn't come any harder than NHS England in healthcare.
Absolutely. And Clive, I've had exactly the same conversation as you've had with Euroking, with a vendor client that I presented safety documentation to the digital clinical safety team and said I have issues with this, and they came back with the same response, said our hands are tied in relation to this. And I was like, but you're the digital clinical safety team for NHS England. Where else am I?
You run the framework. You run the framework.
You created the framework. You implemented the standards. You authored the standards. So where do I go? Where do I go now in relation to that? We're doing some work together in relation to a study around governance for clinical risk management, and we're hoping to sort of publish that and get that out there, really as a what good looks like in relation to clinical risk management and its application in relation to governance. And because we know that health organisations struggle, and you know, it's the work that Liz and her team have done and have put forward has been absolutely fantastic. She's got a great team now. Her approach and their approach, and I know she won't mind me saying, has been groundbreaking, I think. And Leah has been instrumental in actually allowing their clinical risk management system to be shared with other organisations. And I think it's absolutely fantastic.
Well, and that's what exactly needs to happen. You know, this sharing of knowledge is, and I guess that's sort of what the frontline digitalisation team is meant to be doing. The problem is it doesn't have the profile yet to do it. And that's what they need. And, you know, we all need to try and help them to do that better, frankly.
Absolutely. And it's, you know, and I'm tapping straight into, which I've got up in front of me, the patient safety learning, those 10 points. And it's in there around sort of like from EPR implementation. We need to learn, we need to be transparent. And yes, you know, I know we can all sort of like sit here and say, oh, don't share safety case reports, because all people are going to do is going to rubber stamp it as their own. But it's like, it's like, yes, we know that may happen, but that shouldn't stop us. That shouldn't stifle us from actually. It's that knowledge transfer, isn't it? That's what it's all
Well,
about. And
there's
it's
something
really
else,
important.
which is, and I can't believe that this is necessarily true, but who knows? Because we're not America, but maybe. So some of the people that have had issues with some of these systems are frightened to talk about them in a public space because they're frightened to be that they're going to be litigated against by the vendors. Okay, now for these sorts of user groups, sharing that information is critical. I can't imagine that these vendors would be so short-sighted that they would take legal action against people who are all in the NHS generally. There might be private sector in there, but who knows?
Yeah.
From sharing their information to try and make the system safer for everybody and ultimately, of course, patients. That can't be the case. I wonder whether that is a worry rather than a reality. But it would be interesting to try out and see what happens. I mean, certainly if that's facilitated by NHS England under the auspices of the frontline digitisation team, you'd think that would be a pretty difficult thing to actually happen. But who knows?
Well, I think it's happening already, Clive, but that's another conversation, and something we could probably go on about sort of and talk about at length. Clive, it's been absolutely great talking to you. We have covered a number of topics in relation to patient safety, in relation to clinical safety, and it will be interesting to see over the next 6 months, year, 18 months, who knows, in relation to, we have a change of government that is upon us. We know we've got a long way to go in relation to the mess that the NHS is in at the moment. But I think we need to stay positive. We need to move forward. There are some great initiatives out there. Everything that you are doing at the moment, and those organisations that you're working with and supporting, and that you work for and you've established yourself, is absolutely fantastic in creating that movement in relation to digital health and getting it done properly in relation to that. I will put you on the spot. I do this with everybody within the podcast. If there is one takeaway that you could give to, I know you talked about fragmentation as that one word, but if there is one takeaway that you could give to everybody in relation to digital health, their approach in relation to patient safety and clinical safety, what would that be?
It depends on whether they're the buyer or the seller. Which one are they?
Both. Yeah, both.
Both.
Let's go for let's do. You can do one for each.
Okay. Well, actually, as I said earlier, it does apply to both. It's start with the problem, and that probably does apply to both sides actually, because unless you know the problem fully, unless you've identified the cause, unless you know the scale, unless you know where it's happening, who's involved, unless you've got all of that information, nothing that you do about it, regardless of whether that's analog or digital, is actually going to have any impact. And so you've got to really, really know the problem very well. And related to that, you've got to know your audience, you've got to know the people involved, you've got to know the data that's involved or could be involved. So, but it all stems from understanding the problem fully.
Yeah, couldn't agree more. And using that and applying to clinical risk management, scope definition in relation to our projects. If you're not prepared, if you don't know your environment, your user groups, your workflow, your audience, how can you risk assess something if you don't know it? And exactly the same as what you've just alluded to. Clive, it's been absolutely fantastic talking to you. Thank you ever so much for your time for episode 5 of The Only Way is Ethics. And I'm sure we will speak soon. And thank you to everyone for listening. And you can find us and subscribe on Spotify and YouTube. So thank you again, Clive.
Thank you for inviting me. It's been really good. Really enjoyed it.